Okay, these are the first line of treatment and prevention of angina. We have second line agents, but these three groups, nitrates, beta blockers, calcium channel blockers, is a must. Okay, mandatory for you to know. And for each of this group, you need to list the examples of drugs. Okay, so I think for beta blockers and calcium channel blockers, you have learned about it, right? So there won't be much problem on that. In fact, there will be no problem lah at all for this drug or for this lecture, because I think among all the drug used in the treatment of heart problem, whether it's hypertension or arrhythmia or angina or heart failure, is the easiest to understand. Don't you agree? Okay, it's up to you lah. But to me, I think it's the easiest to understand lah. Okay, so for each of this drug, as usual, you need to describe the mechanism of action, the relevant pharmacokinetics, the clinical uses and adverse effects, and also name other relevant drugs used in the treatment of angina. So you already know about the pathophysiology of angina? Yes? No? I assume yes? Okay, this is your pathology lecture, okay? So the first time the symptoms was described or even discussed is in 1772 by William Herbert. This is a physician lah. Okay. There's also a note called Herbert Notes, named after this guy. Okay. But Dr. Herbert described the symptoms of angina as a disorder of the breast, because they are not sure whether it's the chest or the breast or the heart or maybe the lung. Okay. But somewhere the pain is felt at the chest area with strong peculiar symptoms, which is a sense of strangling. Okay, so this is very much different from the pain of other causes lah. Okay, if you have broken bone, the pain is very excruciating pain, it's very sharp pain. But this is sort of like strangling. Kalau dalam Melayu, kita cakap apa? Umpamanya macam kena tekan. Kan? So you have to differentiate this type of pain when you go to clinical practice, kan? Patient come to you, sometimes they don't say they having pain at the chest. Where is the typical part where they complain? Back, yeah, sometimes the back. Most of the time is the epigastric area. So they will complain of epigastric pain. And if you think the epigastric pain, what come across your mind? Gastritis, fatty ulcer, kan? So that is a misdiagnosed lah, most of the time. So if a patient comes to you, a male, especially male, comes to you with epigastric pain, don't put gastritis or fatty ulcer as a first possible diagnosis. It must come to you that patient is having, most likely is having angina, is having a heart attack, is having a myocardial infarct, which is very typical. Sebab if you look at the epidemiology itself, gastritis tak common in male, it's more in female. Okay, so whatever age patient comes to you, 30, 40, sekarang pun heart problem, heart attack is most likely occur in the 30s, the 40s, kan? Tak tunggu 50 lagi dah, muda-muda lagi dah dapat. And with the background of smoking, taking alcohol, so you have to think of angina of MI. Paling high sekali in your possible diagnosis. So this pain cease while they are walking. Cease. Those affected with it are cease while they are walking. So bila berjalan tiba-tiba terberhenti. Bila bercakap berhenti. Bila tengah berlari berhenti, because it's too painful. Okay, but the moment they stand still, all the uneasiness vanish. So this is very typical of angina pain. Felt at the chest, can radiate to the arm, to the neck, and also to the back. Sometimes atypically presented as pain at the back. So very peculiar, kan? So you have to be very careful. If you suspect, macam saya cakap lah, very high risk with family history, very poor social history, smoker, alcohol, so you have to diagnose, or you have to have in your mind the diagnosis of angina or maybe an infarct. Okay, so angina is basically the variants of the ischemic heart disease. is caused by transient coronary ischemia, and in a severe form, it can lead to coronary thrombosis, which could lead to myocardial infarct. So the pain is called angina pectoris. We have stable angina, unstable angina, and also variant angina. So the typical stable angina is a constricting discomfort at the front of the chest, radiate to the neck, to the arm, to the back. Okay, associated with shortness of breath, associated with sweating and feeling nauseous. Precipitated by physical exertion, relieved by rest, or GTN within 5 minutes. Okay, GTN is one of the drugs that is used, which is the organic nitrates. So IHD is the main cause of death in Malaysia, and in 2019, based on the National Health and Mobility Survey, about 15% of total death in Malaysia is caused by IHD. Men are affected more than women, and typical in the age group of 41 to 59. Okay, and common cause of death across ethnic group. Maksudnya Malay, Chinese, Indian share the same risk of developing IHD and death caused by angina. Okay, so there are 3 different types of angina. You have learned about this. You have typical or stable angina, atypical or unstable angina, and vasospastic angina or prismatic angina. So the typical angina is presented with a pain upon exertion and relief by rest, and is caused by atherosclerosis. So there's a plaque building up at the arteries. Okay, atypical or unstable angina meet the 2 above characteristics, which means that patient have pain and provoked by exertion, relief by rest, but there's increase in the frequency and severity of attack. For example, usually the patient has a pain every 3 to 4 months, and this is becoming more frequent every month or every week. Okay, usually it's relieved by 1 tablet of GTN. Now patient has to take 2 or 3 tablets of GTN before he feels relief from the pain. So this is a characteristic of atypical or unstable angina. But sometimes the angina even occurs at rest. Okay, usually the pain is precipitated by walking or doing some work or going up the stairs, but now even when at rest, patient is having pain. Okay, or first timer, patient comes to you with a first time angina, you will treat as atypical or unstable angina. So this is caused by the atherosclerosis, which has developed into clots already. Okay, thrombosis and clots are being developed around the atherosclerosis, and this has high risk to develop infarct and also death. Okay, the third form is vasospastic angina, and this is caused by transient reversible vasospasm. It has nothing to do with atherosclerosis or blood clot. It's just spasm of the coronary artery, and it can occur at any time, even during sleep. So the cause of pain is due to imbalance between the demand and supply of blood and oxygen to the heart. So when there's a case of increased demand, for example, increased heart rate in times of fever or in times of thyrotoxicosis, increase of the blood pressure, okay, patient is hypertensive, has higher risk of developing angina. Myocardial wall tension, left ventricular hypertrophy, increased cardiac contractility. So all of these can increase the demand for the heart to pump a lot of blood and oxygen to the body, and this causes imbalance if the supply is not met. Okay, so what causes reduce in the supply when there's atherosclerosis, stenosis, spasm, endothelial dysfunction, inflammation of the coronary artery, or microvascular dysfunction. So the treatment of angina is the first one to reduce the risk of MI, to reduce the risk of developing infarct and going to death. Improve the quality of life and to tolerate angina with minimum side effects. Okay, sometimes patient has angina, patient is not going for definitive therapy. So definitive therapy banyak lah. So you can buat stenting ke, bypass ke apa kan. So while waiting for the definitive therapy, you want patient to have a normal life or maybe near normal life lah, to improve the quality of life so that patient can go to work, can be with the family, can continue with the social life with minimum side effect. Okay, So you have two groups of drugs that you can use in patient with angina or diagnosed with angina. Okay, the first one is outcome prevention. You want to improve the lifestyle and want to control the risk factor. So these are the drugs. You can give aspirin, which is antiplatelet, or you can give statin, which is anti-hyperlipidemia, and also ACE inhibitor, which is your antihypertensive. Okay, but the treatment of symptoms, which you want to reduce the symptoms of angina, can be divided into two groups: the first line drugs and the second line drugs. So the first line drugs consist of nitrates, beta blockers, and your calcium channel blockers. The second line drugs consist of nicorandil, ivabradine, ranolazine, trimethazidine. So in the current practice, we are still using the first line drugs because they are cheap, okay, available worldwide. Compared to the second line drugs, they are more expensive. Okay, but why they have the second line drugs? In case patient cannot tolerate the first line drugs, or patient have hypersensitivity to the first line drugs, then they will offer the second line drugs. Okay, so this table summarizes all the drugs that are used in the treatment of angina. So you have the first line drugs and second line drugs, and also what are the effects to the heart parameters. Okay, so what are the effects to the heart rate, blood pressure, peripheral vascular resistance, cardiac contractility, and coronary, what is this, vasodilatation. Okay, so this is a good table. So once you finish your lecture, you can go back to this table and look of the full summary of what are the drugs used in the treatment of angina. Okay, so let's go to the first line agent. So we have the first one is nitrate. So nitrate ni very popular. Patient yang ada angina memang bawa nitrate wherever they go. There's always keep nitrate inside the pocket. Okay, so it's available as nitroglycerin or glycerin trinitrate. So ni sama ya, nitroglycerin or glycerin trinitrate, both acceptable kalau you write any of these two. Isosorbide dinitrate, isosorbide mononitrate, and amyl nitrate. It is a mainstay therapy for acute relief of angina attack. So that's why people carry it around. If they feel the pain, they pop in one tablet of nitrate inside the mouth. Okay, so it has short acting and long acting drugs. The short acting is given by sublingual. Okay, GTN is given sublingually, or you can give it buccal. Buccal ni you put between the gums kat tepi gusi. Okay, so the buccal one comes in the form of tablets or spray. For the long acting, isosorbide dinitrate, isosorbide mononitrate, they are given by transdermal patch and also orally lah. Okay, inhalation, amyl nitrate, and intravenous form. So you have intravenous form. Patient datang with you with angina or with MI, sometimes they are given intravenous GTN. Okay, intravenous nitrate. They have high first pass effect, and that's why they are given sublingually or buccally. Very lipid soluble and half-life about 2 to 8 minutes. This is for the short acting one. They are metabolized mainly by two pathways. The first one is in the liver by nitrate reductase. So this is the reductive hydrolysis process, the first phase of metabolism to inactive metabolite. The second pathway is occurs in the blood vessel, where nitrates is metabolized to nitric oxide, NO, and which is the active form lah. And this has a longer half-life, which is about 40 minutes. Okay, which means nitric oxide in itself has a 40 minutes half-life. Okay, so it needs to be metabolized very fast. It's excreted through kidneys. Again, table to summarize. This is short acting one. You have nitroglycerin, isosorbide dinitrate, amyl nitrate, or isosorbide dinitrate and amyl nitrate. And the duration of action is mainly about 5 minutes to 30 minutes. They are given through sublingual and inhaled. Okay, so you use the short-acting one to prevent exertional angina. So patient katakan dia nak naik tangga, okay, so dia pop in, dia tak rasa lagi sakit, tapi dia ambil dulu nitrate before dia naik tangga tu, so to prevent any exertional angina. Or if the patient has having pain, dia terus ambil je immediate pain relief because it's very short acting. Okay, the long acting one given through oral, through patch, through IV, they are all to reduce the frequency and severity of attack, increase the exercise tolerance, and IV is used in the case of very severe recurrent rest angina. So the half-life is very long, taking hours lah, so up to 10 hours, okay, in total. So these are the mechanism of nitrate. It must be metabolized. Okay, the first metabolism of nitrate for the inactive form, but the second form of metabolism is to the active form of nitric oxide. Okay, it will be converted to nitric oxide by the glutathione S transferase and mitochondrial ALDH, and this occur within the vascular smooth muscle. So where is the smooth muscle? Any vessels lah, kan? The coronary arteries, the vein, or the arteries itself. Okay. So what happened to the nitric oxide is that it will bind to the guanine cyclase, where it will convert GTP to cyclic GMP. So when there's increase in the nitric oxide inside the vessel, there's increase in the cyclic GMP. Okay, and this elevated cyclic GMP will inhibit the calcium release, resulting in dephosphorylation of myosin light chain kinase. So what happens is that myosin will detach from the actin, and this will result in relaxation of the smooth muscle. So the end product of it, or the end effect of the nitric oxide, is relaxation of the smooth muscle caused by dephosphorylation of the myosin light chain kinase. Okay, so this figure summarizes what happened with taking of nitrates lah. So it will relax all type of smooth muscle, whether it's a coronary artery or the arteries or even the vein, regardless of the pre-existing muscle tone. So kalau dia spasm ke tak spasm ke normal tone, it will relax all the smooth muscle. Okay, so the first effect is that it will dilate the coronary arteries, hence it will relieve the spasm and blood flow and improve the oxygen supply. So this is what we want for the patient. Okay, this outcome that we want for the patient. On top of that, it will dilate all arteries inside the body, hence it will reduce the arterial pressure. Okay, and this will decrease the afterload of the heart lah. What will happen is that when you reduce the arterial pressure, the effect is that it will stimulate the baroreceptors. Okay, this is the mechanism kan, defense mechanism of the body. It will stimulate the baroreceptors because the pressure is going down. Okay, so what will happen once there's stimulation of the baroreceptors? Patient will have tachycardia, increased contractility, and also salt and water retention. So these are the purple one here is the adverse effect of the nitrates. Okay, we don't want this to happen, but it will happen because of the stimulation of the baroreceptors. At the same time, when you dilate the arteries, patient will have temporal artery pulsation. Patient complain to you with throbbing, headache, and flushing. Okay, another side effect of nitrate. Okay, dilatation of the vein will reduce the ventricular preload, decrease the wall tension, hence reducing the workload and reduce the demand of the heart. Okay, and this is the effect we want. But at the same time, patient can have orthostatic hypotension because the vein is not pumping enough blood, okay, to the brain and to the heart. And patient can have syncope. So this is a complaint of the patient taking nitrates. So there is effect that we want Okay, but there's also side effect for that. But if we weigh the risk and or the adverse effect and the benefit of nitrate, the benefit still outweigh the adverse effect. So it's still a good drug. Okay. And in some way, tolerance can also develop with nitrate. So what happens is that patient usually take one tablet to relieve angina, but later on when tolerance develop, they need more tablets to achieve the same effect. So this is one of the adverse effect of nitrate tolerance. Okay. Okay. So we go to the second group of drug, which is the calcium channel blocker or calcium channel antagonist. There are two types. You already know this. You have non-dihydropyridine, which is verapamil and diltiazem, and dihydropyridine, which is ifeadipine, amlodipine, felodipine, nicardipine. Okay, so CCB is widely used as angina prophylaxis or to relieve the coronary spasm. It's also used as in the treatment of supraventricular arrhythmias and also hypertension. Okay, for SVT or arrhythmia, you use drugs, the non-dihydropyridine group, because it acts on the heart. Okay, hypertension, you use more of the dihydropyridine group because it affects more on the vessel. Okay, for angina, you can use both. Okay. It is given orally and also IV. IV is for the non-dihydropyridine group. It's well absorbed, but undergoes significant first pass effect. It has high plasma protein binding and it undergoes extensive metabolism. So the oral bioavailability of calcium channel blocker range about 13% to 75% for dihydropyridine. Amlodipine has a better oral bioavailability lah. For the non-dihydropyridine, we have about 50% of the oral bioavailability. So it's highly metabolized. Okay, and the half-life range for 1.5 hours to 40 hours. Again, amlodipine is a drug of choice because this one is quite good in terms of oral bioavailability and also the half-life. Okay. So what happened? You have gone through this a few times. It blocks the L-type calcium channel. So it reduces the frequency of channel opening to depolarization, hence reducing the calcium level. So where does it reduce the calcium level? It reduces the calcium level at the SA node, at the ventricular myocardium, at the coronary arteries. Okay. So what happened is that the effect at the SA node, there's a reduced heart rate, reduce contractility, increase in the vasodilatation. Okay, less constricting arteries. So it will reduce the oxygen demand because there's negative inotropy, negative chronotropy, improve the oxygen supply. Okay, and you know it will improve the vasodilatation of the blood vessel, hence reducing the blood pressure and reducing the oxygen demand. Okay. So calcium channel blocker is actually a good drug because it reduces the oxygen demand of the heart and as well as increasing the coronary flow because it reduces the contractility. So less contracting heart, more improving in the coronary flow and perfusion of the heart basically the subendocardial region. Okay. So the effect, the important adverse effect depend on the type of calcium channel blocker. So you know you have the dihydropyridine where the effect is more at the blood vessel, and you have non-dihydropyridine which affects the blood vessel as well as the heart. So if you look here, all calcium channel blocker will improve the coronary blood flow because it will cause vasodilatation again. But the effect on the heart depends. Okay, kalau diltiazem and verapamil, it reduces in the channel. Tapi for this channel, it shares which channel between sodium and potassium. Okay. So what will happen is that ivabradine will block intracellularly. They block here. So sodium cannot go in, potassium cannot go out. So dia macam sort of like delay the diastolic depolarization. So kalau yang blue ni yang normal, tapi kalau you bagi ivabradine, become the orange graph ni. So it's sort of delay. Instead of firing here, of the SA node, it sort of delay a little bit, prolong the diastolic duration, reducing the slope. Okay, tapi the action potential is not affected. So what happened is that it will reduce the heart rate in use-dependent manner at higher heart rate. Meaning that if you take if the heart rate is low, the effect is lesser. If the heart rate is higher, then the ivabradine will tend to slow down the heart rate. Dia macam tu, use-dependent. Okay, so it will not affect heart rate yang normal. Kalau heart rate normal, effect dia hanya sikit saja. So when you reduce the heart rate, especially those with higher heart rate, it improves the microcirculation and coronary flow. Okay, because the heart is not contracting so frequently. Okay, so improve the coronary flow to the subendocardial region. But the adverse effect of that is that patient can have bradycardia, atrial fibrillation, because you are delaying a little bit of the SA node, so you sort of like playing with the contractility of the heart, hypertension and also phosphine. Okay, phosphine ni effect dia to the eye. Okay, you can Google and see what phosphines mean. Okay, again another illustration, it blocks the IF current involved in the sodium and potassium intracellularly, so sort of like delaying the diastolic depolarization. So IF inhibitor. Okay, it will lower the heart rate. Okay, the next drug is ranolazine. Ranolazine ni is a chronic, is commonly used in chronic stable angina, known as the late sodium current blocker. Okay, so what happened is that during ischemia, the sodium channel ni, the late sodium channel, it's not closing. Okay, it's not closing or delay in the closure. So what happened, there will be a massive influx of the sodium, and this influx of sodium will exchange with the calcium through the sodium calcium receptor exchanger lah here. Okay, so what will happen, a lot of sodium inside the cell, sodium will be pumped out, calcium will be brought inside the heart. Okay, so ranolazine affect the late inward sodium current of the cardiac myocytes. Okay, so compared to ivabradine tadi, SA node, nicorandil tadi the blood vessel, but this one is regarding the heart. So ranolazine will selectively, dia memang dia satu je current, current dia inhibit the late inward sodium current, hence preventing intracellular sodium and calcium influx and reducing myocardial stiffness and contractility, promote relaxation and reduce the oxygen demand. So it's sort of like reducing the contractility of the heart. At the same time, it also involved in the metabolism of the heart, where it promotes glucose oxidation. So glucose oxidation ni is an anaerobic metabolism. Okay, so less oxygen needed for this metabolism, so it can produce energy but under ischemic condition. So adverse effect is quite rare. Patient can have dizziness, nausea, constipation and headache. Okay, so these are the normal phase of your action potential. Okay, so you have this one, late sodium influx here. So it prevents this one, hence preventing the influx of calcium in exchange for the sodium inside the cardiac muscle. Okay, the last one is trimetazidine. Trimetazidine ni is a bit different compared to other drugs. This one is a metabolic modulator. It means that it doesn't interfere with the heart rate, it doesn't interfere with the blood pressure or cardiac contractility, but it involves in the metabolism of energy at the myocardium. So what it do is that it inhibits this one, the acetyl-CoA generation, by inhibiting the long chain activity of enzyme acetyl-CoA C acetyltransferase, so L3-CAT. Okay, so acetyl-CoA is not being produced, so the energy is not being produced through the fatty acid oxidation. Inside, it will shift to the anaerobic metabolism, which is the glucose oxidation. So in a normal condition, this one will dominate. The fatty acid pathway will dominate. Okay, but trimetazidine will block this one because it won't generate the acetyl CoA. Hence, the metabolism is being shifted to the anaerobic metabolism, which is the glucose oxidation. So ATP is being produced, but under lesser oxygen supply. Okay. So the adverse effect of this drug is that it can cause GIT disturbance, vomiting, nausea, and headache. And rarely it could affect the blood. It can cause thrombocytopenia, agranulocytosis, liver dysfunction, and extrapyramidal symptoms. So this is the only drug that does not interfere with the function of the blood vessel or the heart. Okay. So which drug to use? There are drugs that you can combine and drugs that you cannot combine. If you look here, a useful combination is denoted by the green line. Okay, so beta blocker you can combine with nitrates or nicorandil because these two are vasodilators. You can combine with a calcium channel blocker. Okay, you can combine nitrates with beta blocker and also ivabradine. Ivabradine tadi kat mana?
It's
kat mana?
It's in it. It's in it.
IF current of the
It's in
SNO.
it.
Okay. So this is a good combination, nitrate, beta blocker, ivabradine and calcium channel blocker. But not recommended. Kita tengok not recommended lah. Beta blocker dengan diltiazem and verapamil, which is a calcium channel blocker but non-dihydropyridine group. Okay, you cannot combine both because
Defects.
patient apa? This one is a negative inotropic, negative chronotropic. This one is also has negative chronotropic, negative chronotropic. Kan? So if you depress the heart, patient terus tak berfungsi heart dia. Your patient is having bradycardia, reduced contractility, is not pumping blood at all. So you cannot combine this one, the non-dihydropyridine group. You can combine with the dihydropyridine group. Okay. Again, ivabradine dengan CCB is not a good combination as well. Okay. Okay, so let's say patient comes to you with angina and bradycardia. Okay, so you want to avoid beta blocker. You know bradycardia, beta blocker can cause bradycardia. Okay, beta blocker can cause bradycardia, so you want to avoid beta blocker and also ivabradine. Okay, ivabradine will depress the SNO tadi kan. So your choice will be nitrates especially and also the calcium channel blocker. Okay, so patient comes to you with tachycardia, heart rate is high. You don't want to use nitrate because nitrate tadi dia punya effect is reflex tachycardia. Okay, and dihydropyridine of the calcium channel blocker because it cause reflex tachycardia as well. So you choose beta blocker or the non-dihydropyridine group, and because it reduces the heart rate. Patient with hypotension, you want to avoid antihypertensive drug, the beta blocker and the CCB, because both can reduce the blood pressure. And you want to avoid nitrate because it can reduce the blood pressure as well. So you take something that doesn't involve the blood vessel, which is ivabradine, ranolazine, and trimetazidine. So these are all the drugs that involve the heart only. Okay, it doesn't have anything to do with the blood vessel. Patient with hypertension, high blood pressure, you can use your antihypertensive drug, which is your beta blocker and dihydropyridine as well. Boleh? So you have to consider all these things. Ini belum masuk lagi masalah lain. Patient ada bradycardia with asthma or patient hypertension with diabetes, kan? So you have to really look of what are the effect, clinical outcomes that you want and the adverse effect of the drug before you prescribe the drugs. Okay. So in summary, what you want to achieve is a balanced supply between the oxygen and also the oxygen demand. Okay. So in terms of improving the oxygen supply, we can give nitrate, CCB and beta blocker. Okay. As well as you want to improve the coronary blood flow lah. Oxygen demand, you want to reduce the oxygen demand. Okay, so you have to control the heart rate, the cardiac contractility and the myocardial wall tension, and you can give drugs such as beta blocker, CCB or ivabradine or ranolazine. Okay, so nitrates and also CCB, it can also dilate collateral vessel. So you have collateral vessel lah dekat you punya heart kan. Apart from the main coronary arteries, we have the collateral vessels. So nitrates and CCB can dilate collateral vessels as well, and all can decrease the intraventricular pressure and reduce the resistance to perfusion. Almost all drugs, okay, because of the reducing contractility and heart rate. Okay, so these are the algorithm of treating angina. So the first line is still short-acting nitrate. You pop in your nitrate sublingually. If the patient is not improving or you want to add some drugs, it will be beta blocker or CCB. It's the first line of drug you want to add because it can reduce the heart rate as well as the contractility. Okay. If it's not improving, you may add or switch to second line drugs. Okay, and this is where second line drugs come in. To prevent the episodes of angina, you give drugs, aspirin, statins or ACE or ARB, angiotensin receptor blocker, and you want to ask the patient to change the lifestyle. Stop smoking, stop alcohol, improve in the diet. Okay, you want to educate the patient as well. So this one is symptoms relief. This one is to improve the outcome of the patient. Okay, to prevent another episode of angina. Okay, that's all. Any questions?